Hey everybody, this is going to be a quick review of valvular heart disease and inflammatory disorders. First, we're going to start out with our valvular heart diseases. Just remember that this is going to be a problem with structure with one of the valves. Make sure you understand the flow of blood coming into the right side of the heart, how it goes through the tricuspid, through the pulmonic valve to the lungs where it's reoxygenated and it returns through the mitral valve and then goes through the aortic valve out back to the rest of the body. So with that in mind, when you're thinking about in terms of where there is more stress on the heart, it's going to be on the left side. So we're going to typically see more problems with the left side of the heart, left valvular problems. Classifications of valvular heart disease are going to either have stenosis or regurgitation. Another word for regurgitation you may hear is insufficiency. Stenosis is a narrowing that impedes blood flow moving forward, where regurgitation you're going to see some of the blood flow backwards. Etiology, it can either be congenital or acquired. Anytime you see the word rheumatic, think autoimmune. Some risk factors: hypertension, rheumatic fever, which is basically inadequately treated strep throat or scarlet fever, infective endocarditis, congenital malformations, Marfan syndrome, which is a genetic connective tissue disorder that can affect the aorta primarily. Valves can be affected primarily by insufficiency or, again, regurgitation, and of course age. Anytime anybody ages over a period of time, structural damage can occur. Expected findings with valvular heart disease: most are going to be asymptomatic until later stages of the disease, and most valvular heart diseases you're going to have a murmur, and the murmur is going to be heard typically in the area of the valve that is affected. Left-sided valve damage can cause an increase in pulmonary artery pressure, left ventricular hypertrophy, and a decrease in cardiac output, which will result in orthopnea, paroxysmal nocturnal dyspnea, and fatigue. So your orthopnea is basically going to be shortness of breath when laying flat, where your paroxysmal nocturnal dyspnea is basically a shortness of breath that will wake somebody up out of their sleep. The most common, like I mentioned before, is going to be left-sided valve damage. In this, when we talk about the mitral valve, when there is involvement, whether it's stenosis or insufficiency, a patient may have atrial fibrillation as a result from the strain on the atrium. With this, you may see pulmonary venous hypertension and a decrease in the ejection fraction as a result. Your symptoms for atrial fibrillation are going to be irregular rapid heartbeat, palpitations, dizziness, shortness of breath or anxiety, tiring more easily when exercising, and possibly fainting or syncope. Mitral valve prolapse: this is just when a portion or both leaflets bulge back into the atrium during systole. There's usually not a lot of problems with patients that have this, because a lot of times there is no difficulties with the actual blood flow, so it doesn't necessarily put them at risk for infection, ischemic heart disease, or effusion, which effusion is buildup of fluid. Septal wall defects: the biggest issue that we run into this, if you look at the picture here, is if a clot forms on this side of the heart and actually travels over to the left atrium and then goes out into the vasculature. Typically, if there's a small clot, it could be filtered out in the lungs normally, but if it does bypass, it can get into the vasculature and go to the brain, which can lead to a stroke. Cardiomyopathies: this is going to be disorder of the muscle that is associated with mechanical or electrical dysfunction. The best way to diagnose these is with the echocardiogram. With these patients, to find their level of tolerance of activity, you typically start with bed rest and kind of increase activity slowly from there. Know the different diagnostics that are used with different cardiac disorders, anywhere from chest x-ray all the way down to angiography. X-ray looks at structure. Angiography is particularly used to look at the degrees of atherosclerosis, and usually, if any is detected, catheterization can be used as well as a diagnostic tool. So when we talk about medications, make sure you understand your medications to help treat valvular heart disease. Diuretics. Know that your class of loop diuretics and thiazide diuretics can cause hypokalemia with patients. And those are going to be the patients that you need to educate about foods that are rich in potassium. Your only really potassium-sparing diuretic that is used is aldactone. And of course, this is the big reason of why we want to treat hypokalemia, is that it can potentiate dysrhythmias. After load-reducing agents, these are going to basically help the heart pump more easily by altering the resistance or the pressure of the load that the heart must eject blood against. So the different types are going to be your ACE inhibitors, your ARBs, your beta blockers, and calcium channel blockers. And I've kind of helped you here to know the endings for the words to help better recognize these different class of drugs. One thing too that, if I want to go back for just a second, when we talk about hypokalemia, make sure you know how to recognize hypokalemia versus hyperkalemia on an EKG. All right, so your after-load reducing agents. So your inotropic agents, the big one is digoxin. That's going to help increase the contractility, improve cardiac output. So it's basically helping to make the squeeze of the heart more efficient when it pumps the blood out into the vasculature. So know your patient teaching if they're having to self-administer, to count the pulse for 1 full minute before taking the medication. If the pulse is irregular outside the limitations set by the provider, a lot of times it's if the pulse rate's below 60 or over 100 that they need to hold the dose and contact their provider. Take at the same time every day. Do not take at the same time as antacids because they can lessen the effects of digoxin. Allow at least 2 hours between the two medications, and to make sure that you know and that the patient knows what the signs of toxicity are, which is fatigue, muscle weakness, confusion, visual changes, and loss of appetite, which is also known as anorexia. Your anticoagulants are typically going to be used for those who have mechanical valve replacement, atrial fibrillation, or severe left ventricle dysfunction. Used mainly with mechanical valves, just because the body recognizes them as foreign and will actually migrate to the area to form clots. So that's why anticoagulant therapy is used more with your mechanical valves. Invasive treatments for percutaneous balloon valvoplasty, that's used to treat stenosis. As you can see in the picture here, balloon comes up, here's a stent, and it's basically kind of opening up the valve. The thing you have to watch, again, anytime you're doing anything to the heart, you're causing an irritation. So what you want to watch is for ventricular arrhythmias. Obviously, anytime you're doing anything invasive to try to open up a valve, some complications are going to be regurg, emboli, damage, rupture, and perforation of the ventricle. Other invasive treatments, you don't need to really know these for testing, but just know, depending on what the issue is with the valve, that they can do procedures in different parts. So if it's part of the leaflet, or if it's actually, if the chordae tendineae are stretched, they can do repair on that versus the actual valve itself. Valve replacements, talked a little bit earlier about valve, mechanical versus tissue valve. Mechanical valve will require lifelong anticoagulant therapy like Coumadin or warfarin, and that would be monitored with the PT and INR. Make sure you know your different times, your therapeutic times for that. Tissue valves typically need to be replaced every 7 to 10 years. Client education with valvular disorders are very similar to patients just with cardiac issues in general. Make sure that you know these, and in particular your daily weights, activity with rest. Read your over-the-counter medications to avoid certain medications that have alcohol, ephedrine, and epinephrine that can perhaps cause dysrhythmias, report rashes. So just kind of have a good sense of all of these different teaching points. Inflammatory disorders, so we're moving away from structural disorders into inflammation. So again, if it ends in itis, it means inflammation. So inflammation to the heart is an extended inflammatory response that often leads to the destruction of the healthy cardiac tissue. Best way to decrease inflammation is through health promotion and disease prevention. So early treatment of streptococcal infections, basically untreated strep. So if you have these patients, if they're presenting, big thing you always want to check, signs and symptoms of strep. What is common with strep throat, which is a terrible sore throat. So make sure you understand what precipitates it. So strep throat, make sure you have early intervention. Untreated scarlet fever can lead to rheumatic fever, and of course rheumatic fever, at that point you have an immune response that starts to attack healthy tissue in the body, like the heart. So then we have our prophylactic treatments like antibiotics for patients where they have other issues going on that would warrant prophylactic antibiotics for dental and respiratory treatments. Again, somebody who maybe has a valve replacement and has had a history of infective endocarditis, they would probably be a good candidate to use prophylactic antibiotics. And of course, our vaccinations for both the flu and pneumonia, particularly in our elderly population, and that can also help decrease the incidence of myocarditis. So risk factors for inflammatory disorders range from everything from congenital heart defects all the way down to lower socioeconomic status. And kind of in between, IV drug use, rheumatic fever, to school-aged children with long durations of streptococcal infections. So pericarditis, know that it mimics the symptoms of an MI. It just mimics it. It's an inflammation of the pericardium. It commonly follows a respiratory infection. It can be due to myocardial infarction, but the signs and symptoms of it seem to mimic it as well. So it can be secondary. Findings: chest pressure, pain that is aggravated by breathing, especially on inspiration, breathing in, coughing, or swallowing. You can hear a pericardial fiction rub at the left lower sternal border. Shortness of breath. Patient will have relief of pain when sitting and leaning forward, so the tripod position helps alleviate some of the pain. They can have elevated cardiac enzymes. What is going to be a good indicator of inflammation in the body is a couple labs, the ESR and the CRP. The CRP is more indicative of an acute inflammatory reaction. Patient might have elevated ST segments in all leads, and their echo can show some inflamed heart layers. What's going to make pericarditis stick out from an actual MI? Like we talked in class, a person with MI is going to be have positive troponin test, but it's going to be what a physician will see, unlike the echo, is the fluid, and which is the effusion, and also the tamponade. So that's going to be more indicative, just because that space in the pericardium is going to fill with fluid. Treatment, you're going to address the inflammation, and depending on the cause of the pericarditis will dictate whether you use an antibiotic or an antifungal. Now, if there is too much fluid built up and is causing tamponade on the heart, a pericardial centesis will be performed, where they actually insert a needle into the pericardium to aspirate fluid. The fluid is typically then sent to lab for cultural sensitivity. And the big thing, even though if you pull the fluid off, you have to monitor for the reoccurrence of cardiac tamponade. Positioning and psychological support is very important for patients, so this tripod positioning will help relieve a lot of the pain, and you want to make sure that they restrict their activity. So complications, the two complications that are most common with pericarditis are going to be pericardial effusion, which is fluid in the pericardial sac, and cardiac tamponade, which is the compression of the heart from the fluid buildup. This is confirmed by X-ray or an echo. Signs and symptoms of cardiac tamponade: difficulties breathing, dizziness, feeling a tightness in the chest, an increased restlessness, pulses paradoxis, which is a decrease of 10 millimeters per mercury or more in the systolic blood pressure during inspiration, tachycardia, muffled heart sounds, again, because you see this heart is kind of swimming around in a sac full of fluid, so the heart sounds are going to be muffled, jugular vein distension, and monitoring should be done just to watch for arterial pressure. But again, the two major complications: pericardial effusion, which is buildup of fluid, and tamponade. So myocarditis is going to be inflammation of the actual heart muscle itself. So let's think about the heart muscle, what its job does. And so when you look at the findings, you're going to have issues with how the heart functions, how it pumps. So you'll see dysrhythmias. You can see that it is swollen, so the cardiomegaly. Can have a friction rub auscultated in the lungs, and it depends on what the cause is. You may see elevated cardiac enzymes and increased white blood cell count, but that's typically not common. And again, those inflammation markers in the labs of the elevated ESR and CRP, which are indicators of inflammation in the body. And of course, an echo will show the inflamed heart layers. Treatment, again, you're going to address the inflammation. And since we're talking about the heart muscle itself, that because it's the heart muscle that's going to pump blood, if there's some agitation with palpitations, dysrhythmias, ACE inhibitors and beta blockers may be used to reduce congestion and improve the overall dynamics of the cardiac muscle. It can be life-threatening with ventricular arrhythmias. So again, it is a good reason to address a patient that has myocarditis. Rheumatic endocarditis, we've kind of moved from the outside of the heart into the innermost layer of the heart, which is the endocardium. So this is going to be an infection. Usually it can be followed by streptococcal pharyngitis. So you have strep throat, scarlet fever that can lead to rheumatic fever that can lead to rheumatic endocarditis. And again, you have to know your signs and symptoms of what is strep throat. It is a terrible, terrible, terrible sore throat. If it goes on too long, it can produce lesions in the heart. Findings: fever, chest pain, joint pain, because remember we're talking about rheumatoid, autoimmune. It's not just affecting the heart. Tachycardia, shortness of breath, rash on the trunk and extremities. Anytime you see involvement with strep, you're going to see a possible pickup in terms of rash on the trunk and extremities. Friction rub, murmur, and muscle spasms. And as you can see here, rheumatoid endocarditis, because it's the inner layer, can cause mitral stenosis and regurgitation. Treatments: you want to help prevent through the proper use of antibiotics and fully finishing this course of antibiotics. NSAIDs to reduce inflammation and lower the risk of heart damage. If the patient is exhibiting any symptoms of heart failure, use those medications. And medications might be long-term, depending on to prevent further attacks of rheumatoid fever. And if there is damage of valves, a patient may need valve replacement. Complications: bacterial endocarditis, complications of pregnancy and delivery due to the heart damage, and ruptured heart valve. Infective endocarditis, you're going to see this more in patients that have had structural cardiac malformations, cardiac devices like a pacemaker, prosthetic heart valves, or IV drug use. So invasive procedures like dental procedures, body piercing, tattooing can allow bacterium to travel and get to the heart, can lead to infective endocarditis. So sometimes high-risk behaviors will put a person more at risk, like the IV substance abuse. So findings: fever, flu-like manifestations, murmurs, petechia, positive blood cultures, the splinter hemorrhaging, which is basically the red streaks on the nails, or blood burst blood vessels in the retinas, which are called Roth spots. And obviously if this is an infection, they're going to have an elevated white blood cell count. Treatment: going to have to figure out who is the culprit. So you're going to need to do blood cultures to determine the most effective antibiotic. If it is fungal, then it'll be an antifungal. And here's the key thing about this. It is very difficult to treat, so a person is going to need several weeks of IV antibiotics. Several weeks. Complications of somebody who has this: destruction of the heart and to other organs, cerebral vascular complications like stroke, valvular dysfunctions, and first, second, or third degree heart blocks. So here are some pictures of the splinter hemorrhages and the Roth spots. So I hope this overview helped. Just kind of recap some things. If you have any questions, you know where to find me. Take care.